Good morning, everybody. So we will report indeed the primary result of this phase 3 study that compare pembrolizumab plus chemoradiation versus placebo plus chemoradiation for locally advanced head and neck squamous cell carcinoma. So have a look at my disclosure. I'm advising MSD for this protocol since 7 years without any personal financial compensation. Head and neck cancer, the squamous subtype, most commonly arise from the mucosa of oral cavity, hypopharynx, larynx, and oropharynx. It's the 7th most common form of cancer, with around 600,000 new cases per year worldwide. We have two primary causes. The first one is alcohol and tobacco for all the subsite, or the human papilloma virus only for the oropharynx subsite. The standard therapy for unresected, locally advanced squamous cell carcinoma of the head and neck is concurrent chemoradiation with high-dose cisplatin. For this specific subgroup of patients, no progress has been made for the systemic treatment since more than 20 years. Despite this heavy treatment, prognosis remains poor, with less than 50% of the patients free of disease at 3 years. The 5 years overall survival rate is around 50%. We know for a first-line recurrent metastatic setting that pembrolizumab monotherapy for patients with a tumor that expresses PD-L1 or pembrolizumab plus chemotherapy improves survival. So here you have the design of the study. So it's patients with newly diagnosed, treatment-naive, unresected, locally advanced squamous cell carcinoma of the head and neck. So patient treated with a curative intention. It's locally advanced disease. It means patient with disease more than 4 centimeters. This is going to invade the adjacent organ or lymph node invasion. And the patient must be candidates for definitive high-dose cisplatin chemoradiation. We randomized 804 patients between chemoradiation plus pembrolizumab versus chemoradiation plus placebo. We start pembrolizumab or placebo 1 week before chemoradiation, and we gave 17 cycles. The treatment was continued until the 17th cycle or until progressive disease or intolerable toxicity. The primary endpoint of the trial is event-free survival. This includes death, progression according to RECIST, or also pathological proven local regional relapse, since indeed RECIST criteria cannot diagnose all time the relapse of the treatment failure in this disease. The secondary endpoint was overall survival and safety. So the primary endpoint, event-free survival on the intention to treat population, was not met. However, we observe a favorable trend in favor of pembrolizumab plus chemoradiation compared to placebo plus chemoradiation with a hazard ratio of 0.83. with a 95% confidence interval between 0.68 to 1.03 for a p-value of 0.04. The efficacy boundary for this trial was 0.02. Median event-free survival was not reached in the control arm, in the pembrolizumab arm, but was 46 months in the control arm. The 2-year event-free survival rate was 56% in the control and 63% in the pembrolizumab arm. Overall survival was similar between the two groups, with a 3-year overall survival rate of 70% for control and 71% for the pembrolizumab arm. We performed an exploratory analysis in patients with high expression of PD-L1, meaning CPS 20 or higher. This is 36% of the patients, so 291 patients, nicely balanced between the two groups. For this subgroup, if we look at the event-free survival, the hazard ratio is 0.73 in favor of pembrolizumab, and the 2-year event-free survival rate is 62% in the control and 71% in pembrolizumab. If we look at overall survival for this subgroup of patients, the hazard ratio is 0.67, and the 3-year overall survival rate is 73% for the control and 79% for the pembrolizumab arm. In conclusion, pembrolizumab plus chemoradiation was associated with a favorable trend toward improved event-free survival versus placebo plus chemoradiation in patients with locally advanced head and neck cancer. Hazard ratio 0.83, p-value 0.04. This is not statistically significant. 2-year rate of event-free survival is 63% versus 56%. As observed also in the recurrent setting, PD-L1 expression measured by CPS and the technology used in this trial may be an informative predictive biomarker. For patients with PD-L1 CPS 20 or higher, event-free survival rate at 2 years is 71% versus 62%. Overall survival rate at 3 years is 79% versus 73%. I didn't speak about that in the interest of time, but we have no new safety signal with the combination of pembrolizumab plus chemoradiation. And I would like to highlight that locally advanced head and neck cancer remains a challenging disease to be treated. Thank you.
Hi, Neil Osterweil with MD Edge for Professor Machiels. How can you justify your conclusion about a benefit when, obviously it didn't meet the primary endpoint? Was all of that benefit explained by the patients with a CPS score higher than 20?
Yeah, that's a good question. So statistically, it's negative per statistic, but we see in all the subgroups, you will see this afternoon a benefit. When we designed the trial 7 years ago, we didn't know that CPS or PD-L1 could bring something. We learned that 2 years ago with the recurrent metastatic setting trial was reported. So we could not change the primary endpoint of the trial just due to honesty, but clearly it looks, but it needs to be validated in a phase 3 trial that when you have PD-L1 overexpression, maybe the benefit could do better.
Pierre de Waal, Oncohemato, Belgium. Professor Machiels, regarding the results of your study, would you recommend the use of pembro for this type of patient with CPS over 20?
That's a good question. I don't think so, and certainly not because it was not the primary endpoint and it was an exploratory endpoint. So I think it's a clear indication that probably a subgroup of patients will benefit from this approach, but I will not put this as a standard of care because it's an exploratory analysis at this stage. But it's encouraging for this disease.